Hi, everyone. It's my pleasure to welcome you today to September's NBC Impact Series event. My name is Casey Volpe, for those of you that haven't attended before, and I'm with Susan Jacomans Community Education and Outreach team. The programming for the series is envisioned as a year-long conversation with attendees presenting new topics, new information, new speakers every month, the topics picked by NBC patients. So today's topic is NBC and sexual health, and our featured speaker is Dr. Dawn Dizon. So before we begin, I'd like to thank our sponsors for supporting the NBC Impact Series. They're what makes this possible. They're why we get to pick the topics you want and find the speakers you're excited to hear from. So thank you to AstraZeneca for being the technology sponsor for this year's event series. The virtual setting means NBC patients, no matter where they live, can be part of this community. So we also would like to thank our premier sponsor, GE Healthcare. And last but certainly not least, Walgreens and Daiichi Sankyo, our signature sponsors. Quick housekeeping note before we dive in. While our speakers are talking, please use the Q&A feature in Zoom to get your questions in. Once the presentation is done, we'll get through as many as possible. And just please remember, our speakers can't give personalized individual medical advice, so just do your best to keep your questions as general as possible. And like I said, we'll get through as many as we can. So now we are very excited you're joining us. To start, I have the immense pleasure to introduce you to our moderator, Nancy Herard-Marshall. Ms. Herard-Marshall was diagnosed with MBC in 2020. In the short time since her diagnosis, she has developed relationships with Komen, LVBC, Touch the Black Breast Cancer Alliance, and Share MBC groups. She has made personal and lasting connections with individuals in these groups, as well as participated in panels and a fashion show for breast cancer awareness. She has addressed the patient perspective of Black women with MBC and the disparities they face, as well as individuals with MBC, with respect to the importance of palliative care and complementary and integrative therapies. She continues to learn more about her MBC community and looks forward to merging her work as a patient advocate, licensed creative arts psychotherapist, and spiritual life coach to help facilitate healing within the community. And on a personal note, she is just a fabulous individual who I truly enjoy working with, hearing from, and collaborating with on this series and at Komen generally. So it's my pleasure. Nancy, the floor is yours.
Thank you for that introduction. That was wonderful. I truly appreciate that. Hello, everyone. As Casey mentioned, my name is Nancy Herard-Marshall, and I was diagnosed with metastatic breast cancer in January of 2020. With that said, this is a very important topic to me. So I'm very grateful to be moderating today. I have a partner, and intimacy and sexuality is very important to me. And I noted that in my early stage diagnosis in 2013, plus my MBC diagnosis in 2020, it was never discussed. My oncologist never discussed having, how cancer affects sex and sexuality. So this is truly an important conversation to have. And I would love to introduce our speaker today, Dr. Dawn S. Dizon. Dr. Dizon, let me just move this out of the way. Let's see, okay. Dr. Dawn S. Dizon is a professor of medicine and professor of surgery at Brown University and serves as the vice chair of diversity, equity, inclusion, and professional engagement at SWOG Cancer Research Network, a member of the National Cancer Institute's National Clinical Trials Network. He's a medical oncologist specializing in pelvic malignancies, survivorship, particularly as it pertains to sexual health for men and women with cancer, and social media. He grew up in the Pacific island of Guam and completed undergraduate and medical school at the University of Rochester in New York. Dr. Dizon trained in internal medicine at Yale New Haven Hospital and completed a fellowship in medical oncology at Memorial Sloan Kettering Cancer Center in New York City. He's a director of the Pelvic Malignancies Program and director of Hematology Oncology Clinics at Lifespan Cancer Institute, director of medical oncology at Rhode Island Hospital, and associate director of community outreach and engagement at Legarreta Cancer Center at Brown University. Among his other roles, he is co-chief medical officer at Global Cancer Institute and sits on the boards of multiple nonprofits, including the Hope Foundation for Cancer Research and the LGBTQ Cancer Network. Dr. Dizon is a founding member of the Collaboration for Outcomes Using Social Media in Oncology and is active on many platforms, including Twitter, Instagram, Facebook, TikTok, and Mastodon. Follow him at Dr. Dawn S. Dizon. Welcome, Dr. Dizon. We are so happy to have you.
Thank you so much for having me. It's really great seeing you again, Nancy, as always. I'm just going to bring up my slides and we can get started. So this is a topic that I have addressed since my fellowship. And actually, I've moved institutions every 7 or 8 years. And at each place, I'm always shocked when I find that there's no sexual health services. So I've had to start 3 sexual health clinics, most recently the one at Rhode Island Hospital, but before that, started one at Mass General Hospital in Boston, as well as one in Women and Infant Hospital of Rhode Island, where I was prior. I will be talking about sexuality and context specifically as much as I can for people living with advanced or metastatic breast cancer. But first, a little bit of the basics. This is data that I love to quote. It's old, it's over 10 years old, but it came from Livestrong. And really, it went into what are the long-term issues for people who have been diagnosed with cancer and treated. And what was important about this was that it was a 3,000 strong survey, but it wasn't all people just with a single cancer. So these were younger people, educated. But breast, colorectal, lung cancer, this is a very diverse population. And what we found in this study is that almost 60% of people, over 60% of people, have issues related to sexual function and sexual satisfaction. And I think the third bullet is actually even more important, is even with how much people struggle with sexuality after cancer or with cancer, less than half are receiving any medical care for those issues. And it's important because I think if all of you thought, what does he mean by sexuality? You're going to come up with different answers. For women, sexuality is not just about intercourse. It comprises multiple, what we call domains in sexual function, from intimacy, sensuality, to one's own view of body image, the experience of arousal and desire, climax, and then most importantly, satisfaction. So this is what we talk about when people are talking, when people are referred to me to discuss sexuality, sexual health. It is not solely about an activity. And this is important. I always phrase this as a true or false question. If you think of men diagnosed with cancer and women diagnosed with cancer, are they impacted sexually in the same way? And the answer is they are not impacted on the same way. When we think of men and sexuality, we think of erectile function. It's on or it's off. When men are erect, that's really the driving force towards intimacy. Intimacy is tied very closely to sexual activities and penetrative intercourse. And when penetrative intercourse is no longer in the picture, say, someone who is prostate cancer, who is no longer able to experience erections, one of the things that has been reported consistently is that men walk away from sexual relations. The theory being, why go to first base if they cannot go home? They can't hit a home run. This whole idea is that, if I can't have an erection, then there's no point. Again, this is very much informed by our own societies, but our own ideas of machismo, for example. But for women, it's a far more complicated process. It is not an on-off switch. It is much like a computer board. Before someone was diagnosed with cancer, they, it's just like a computer. You turn it on, it works, something appears on screen, you do your work, you're satisfied, it goes in, and you go on with your day. But imagine when that computer breaks. Okay, say you turn it on, it might whir a little bit, but there's nothing that appears on screen, and you pound that keyboard and nothing's happening. That anxiety and that frustration that happens is almost similar to what women experience when their sexuality is disrupted from cancer, cancer therapy, continuation of cancer therapy, and the onset of metastatic disease, the computer isn't working and no one has taken the time to explain it. And this is an issue that is almost universal of every woman that I see in my own clinic. So what I do in my practice is actually go back to the beginning to help explain sexuality in the context of cancer, in the context of prior treatments. And what I use is Rosemary Basson's model for female sexual health. Now, Rosemary Basson, gynecologist, not a cancer specialist, but there is data that this resonates. Her model resonates with people treated for cancer. And I can tell you after years of explaining Rosemary Basson's model, if it makes sense to people that I treat. What this model starts with is here, this brown arrow, which is this asexual or the experience of sexual awakening in women begins with the want of intimacy, that sort of want of something else in one's life. That leads them to realize when certain body areas are touched, they experience arousal. This experience of a heightened arousal sparks desire, and when desire is satisfied, the circle can propagate. Cancer treatment, whether the diagnosis itself, surgical, medical, radiation therapy, treatments beyond that for metastatic disease, it can actually break all of these arrows, and the circle propagating forward can be disruptive. But here's the most important point about Rosemary Basson's model. It does not require satisfaction be governed through sexual activity. It doesn't require that sexual activities, whether penetrative intercourse, self-stimulation, that is not the link between desire and satisfaction. Women can experience satisfaction in various ways and reclaim sexual health. The example I often give to people is, have you ever had a hard day after you've been diagnosed with cancer and you come home and your partner is cooking you dinner or is doing the dishes without being told or brings you flowers? There is that sense of heightened emotion and that sense of satisfaction which can feed intimacy. It has nothing to do with penetrative intercourse or intercourse at all. This is not saying that intercourse is not something women enjoy or want in their lives. Absolutely they can. But it is not tied to the experience of intimacy. Intimacy and intercourse are entirely different experiences for women. There is this other concept that is more specific to people treated for breast cancer, and this concept came from Jennifer Goss at Women and Infants Hospital, and I worked with her, and we termed it breast-specific sensuality. To explain this graph, she did a convenience sample. So everyone who walked in for a post-operative follow-up from breast cancer, she gave them the survey, and it was really, was chest play a part of your sexuality before surgery and then after surgery? And these were the rates. So what you're seeing is that before surgery, the chest wall, the breasts, are an erogenous organ. 80 to 95% of women felt it was important and a part of sexuality. It is lost with breast surgery. It is lost by 10 percentage points with lumpectomy or breast conserving surgery, and it is lost in those who had a mastectomy by a significant amount. It's almost half still consider their chest part of sexuality. And this loss is not made up for by reconstruction, but the numbers are similar between breast conserving surgery and reconstruction. When you go on and ask them, what is the experience when your treated breast or chest wall is touched? What is the experience with that caress? What you're seeing in the pale orange is that almost half of women treated with lumpectomy and presumably with radiation as well do not experience anything when their treated breast is touched, or they experience something unpleasant. That number is far higher after modified radical mastectomy with reconstruction. 7 in 10 have an unpleasant or anesthetic sensation when their chest wall is touched. the experience of breast cancer, the treatment for breast cancer, causes the sacrifice of breast-specific sensuality, which is a very large driving force for arousal. But it's important that your doctors talk about this, just like Nancy was saying, is because there are things that can be done for this. And I'm just going to go you through how I counsel women. And first, I talk about vaginal health, treating the vaginal vulva, as you would any other part of your body, your skin, your hair. It needs continuous maintenance. And if we can maintain a more healthy vaginal vault, sex becomes easier and it can become more pleasurable. But there are also things that can be done to help specifically with sexual function. The name here is GSM, or genital urinary symptoms of menopause. And the hallmark, the thing that everyone should try first, is vaginal moisturizers. This is not a lubricant. This is a moisturizer, much like lotion is a moisturizer for skin. There are many types of moisturizers, polycarboxylic base, there's vitamin E, natural oils that should be used externally rather than internally. There's a parabens-free formulation, parabens being a very weak estrogen in the lab. And there's also hyaluronic. All of these are available without a prescription. What none of them tell you is how to use them. And if you read the package label, it's usually 1 or 2 times a week, sort of like whenever you want. The instruction I'm finding that is most helpful for people who experience it after a cancer diagnosis and treatment is to use it frequently, 5 times a week, and even can be reapplied 1 hour before any planned intercourse. So again, these moisturizers can do 2 things, and it has been shown in a clinical trial with the polycarboxylic based moisturizer. It can almost mimic the effects of estrogen, and it can help alleviate pain with intercourse. And these are the numbers in a very old study from 1997. 60% had improvement in painful sex with the use of a polycarboxylic based moisturizer on the market as Replens. But another number that I always bring out is 40% improved on a placebo, meaning to me that just giving voice to these concerns is treatment enough. There's also a vaginal laser that's available. It's usually given as 3 administrations. There's very little data for people who have been treated for breast cancer, and there is no data on women living with advanced or metastatic disease on endocrine chemotherapy or immunotherapy. So the only data I found was from 2016, and this was not a clinical trial. This was just a single-arm study of 50 women who underwent an oncologic menopause. And what you're seeing here is improvements in painful intercourse using a very standard visual analog scale. There was improvements in atrophy or thinning of the vagina by the Vaginal Health Index, or VHI, and that these persisted for almost a year in over half of those who had a laser. The issue is this: in 2018, reports had been coming into the FDA that people were being injured with lasers. And this led to this warning in July saying that this could result in serious side effects, including vaginal scars and burns. There is a cooperative group called Alliance who's trying to do a vaginal laser therapy randomized trial against sham. So let's hopefully gather some data. I do not believe that trial will be open to women with metastatic disease. What about vaginal estrogen? This is more of an issue that I find in people who are on newly diagnosed or finished treatment with curative intent and are on endocrine therapy. But it is still something that I also discuss in women with a hormone-positive metastatic breast cancer. These are the 3 things that the American College of Obstetrics and Gynecology has said, that non-hormonal treatments with, say, moisturizers is the first line of choice, but if someone does not improve on moisturizers, vaginal estrogen therapy can be used because the data does not show, convincing data is not available to show it impacts on breast cancer outcomes. Now, all of that changed with this study that was published last year. It was a cohort population-based study from the Netherlands looking at postmenopausal women with ER-positive breast cancer who never received chemotherapy. And they wanted to see what is the recurrence risk associated with vaginal hormone therapy. First, you'll note that if you just go through here, these are the people who either had no endocrine treatment, which was surprising, almost a third. 2,000 had tamoxifen, 400 had an AI. The vast majority had tamoxifen followed by an AI or some sort of sequence. But if you look at vaginal estrogen therapy numbers, it's very small. These numbers are very small. Now, at 15-year follow-up, this is what they reported with vaginal estrogen therapy in terms of a recurrence risk. There was no difference in in the risk of recurrence at 15 years with vaginal estrogen therapy. In fact, there appeared to be a mortality benefit, meaning women lived longer on endocrine therapy, whether vaginally or orally, which I think is striking. Now, if you look here at endocrine therapy among women treated with an AR, AI, and tamoxifen, there was a signal at 15 years, almost a 40% increase in the risk of recurrence. Now, that sounds very alarming, but here's the thing. These population-based studies should be considered hypothesis generating because of three issues. One, they cannot really comment on the adherence to the endocrine therapy. In fact, in the study, adherence to endocrine therapy was classified if you were without evidence of disease at 5 years. So if you were without evidence of disease, you were clearly taking your endocrine therapy. And if you had recurred, you were called non-adherent, which is problematic. Second, they couldn't comment on the frequency of use of vaginal estrogen therapy. In fact, if you filled one prescription in 2 years, you were counted as using vaginal estrogen therapy. And they could not comment on the formulations used. These are necessary limitations in population-based studies. The fourth is that they did not collect data that could have confounded this use, including information about lifestyles, alcohol use, cigarette smoking, not being very active, for example. The findings of a recurrence risk was really based on this subset analysis of people with AI, but the major analysis showed a reduction, no change in the recurrence risk and an improvement in mortality. Now, with oral therapy, there was also this, there was no difference here in mortality. The hazard ratio was 0.94, 95% confidence interval across 1.0, not a significant risk. But this contradicts a randomized trial called HABITS. And in HABITS, there was an increased risk of recurrence for women who were on endocrine therapy, taking it with curative intent, who also took menopausal hormone therapy. They had a higher breast cancer event rate limited to those with hormone-positive disease. The question, though, for people living with metastatic breast cancer is whether or not estrogen is ever an option for metastatic disease. And I'll point you to this study by Matt Ellis, which was published in 2009. This was a phase 2 study of estradiol given at 6 or 30 milligrams a day in people who had metastatic disease treated with an aromatase inhibitor, who were progression-free for at least 6 months, or cancer-free for at least 2 years after their adjuvant use. So all of them had metastatic disease, but had responded to an AI. They were given estradiol. It was a phase 2 study without a comparator. But there was a clinical benefit to estrogen that was not dose dependent. So you could take the lower dose or the higher dose. 3 out of 10 people either responded or achieved stable disease for at least 6 months. So again, estradiol is oftentimes viewed as a complete prohibited therapy in metastatic breast cancer, especially if it's hormone receptor positive. Suffice to say, I don't think we fully understand the endocrine axis And this shows that estradiol can actually be used as a treatment. In fact, tamoxifen can cause uterine cancer, but as someone who treats metastatic uterine cancer, one of the drugs we use to treat metastatic uterine cancer is tamoxifen. So what about sexual comfort? Just quickly, there are vaginal lubricants. Saliva is not a lubricant. Moisturizers, for the most part, are not lubricants as well, although that parabens-free formulation I mentioned before, Luvena, can be used as a lubricant. Limited comparative studies for the water or silicone-based lubricants. I found this one study in 2011 that did look at this in over 2,400 women. No difference between water or silicone-based lubricants except a water-based lubricant preferred for women having anal penile intercourse. What about natural oils? Can you use olive oil, coconut oil for penetrative intercourse? Typically, we say don't use it because of a theoretical risk that you may get an infection from it. That's never been borne out in clinical trials, but it is dogma you may hear. This is a very small study called Overcome. It was published 10 years ago, 25 women, but one of the interventions was olive oil used for sex. And at 12 weeks, 73% of people really liked using it. What about pain with penetration? If you are experiencing pain with penetrative or attempted penetration, you need a pelvic exam. The term for this is dyspareunia, but there are two types of pain. One is localized to the entry of the vagina, called the vestibule, and the other occurs with thrusting, called vaginismus. It's important because if you have pain limited to the opening of your vagina, if you have vestibular tenderness, it can be fixed very, very quickly with water-based lidocaine, so-called aqueous lidocaine, very dilute, 4%. And this was proven in a randomized trial of 46 breast cancer survivors, lowered pain score at 1 month compared to placebo, with 90% experiencing comfortable penetration, and almost over 95% who were abstinent, resuming penetrative intercourse once they got aqueous lidocaine, applied for 3 minutes onto the vestibule, not within the vagina, but onto the vestibule for 3 minutes before planned penetration. And the other thing to know, your partner, if he has a penis, does not experience anesthesia. Vaginal dilators are the treatments for vaginismus. If you're having a spasm, we want to address the spasm. Vaginal dilators, although there's very little data on the efficacy, is really the only thing that we have that can help with spasm. Sometimes I will try for about 2 to 4 weeks, and if there's no real improvements, I refer people to pelvic physical therapy. There are drugs available for sexual interest, but oftentimes in the population treated for cancer, they will tell me, I have no desire for intercourse, I have a low interest level. When you walk it back, it's because of pain, it's because of dryness. So addressing the symptoms causing the low desire is important, because if you think about it, why would you ever want something that is not enjoyable? Okay, that really explains that. But there is a situation where women have intercourse and it's pleasurable and enjoyable, but once it's done, they don't want it ever again. That is a primary interest arousal disorder, and there are medications for women who do not have a history of cancer, including daily use of flubanserin, as needed use of a sub-Q injection called bremelanotide, and bupropion, and testosterone. All of them can be used, as well as DHEA. Evidence after cancer, the only one with evidence that it works is dihydroepiandrosterone or prasterone on the market that does have evidence that it is helpful to help with sexual function after cancer. So the bottom line is sexuality is a human right, and you don't give up that right if you're living with metastatic disease. It's important, and as important for everybody as it is to make sure that we discuss fertility with younger patients. We should expect oncology clinicians, and this is your doctor, but also your nurse in infusion, your nurse in the clinical area, to help explore and discuss these issues with you because it's important in quality of life. And if we all accept that sexuality is an important component of quality of life, we do no one a good service by ignoring it. Because after cancer, everyone deserves a sex life, including the young adult, the older patient, people in relationships, people not in relationships, lesbian, gay, bisexual, transgender, and queer patients. You, with advanced or metastatic disease, deserve a sex life, as does your oncologist. Cancer is a social disease, and we need to make sure that we address this issue for you as well as your partner so that you can move forward in the life that you want for yourself. Thank you for having me.
Wow. Thank you for that, Dr. Dizon. That was a lot of really important information, jam-packed, really, really, and that was wonderful. So let's get right into this. First question that we have, let's see. Okay, so Dr. Dizon, what's the most common problems related to sexual activity among those with MBC that you see in your practice, and what can be done to relieve those issues?
Yeah, I think there's going to be two real issues that I see. One is that for some reason, women have heard the message or are given the impression that they should not expect sexual life if they're living with metastatic breast cancer, because they should be focused solely on living, as if sex is not part of living. So what ends up happening is that women find me for consults, or their doctors come to me and say, I have someone with brain mets and they want to talk about sex. Do you know who can see them? And when I say, I do run a sexual clinic at our center, they're like, oh, I didn't think you saw people with metastatic disease. So I think that this perception and the bias that metastatic disease means the death knell of your sex life is one that I'm constantly saying is not true. The other, though, is the issues with people in relationships, especially if someone has gotten very sick at points with metastatic disease where the partner has been a caregiver. Sometimes I find it very difficult to get people, sometimes they find it difficult to reestablish a sexual relationship when the person living with metastatic disease, her health is intermittently impacted negatively, such that your romantic partner becomes your caregiver. And then balancing those roles becomes very, very difficult. And part of what is so important is to make sure they both are in the room to express goals, wishes, desires, and then create a plan that they both feel comfortable with. And I find it's not a language people are familiar with, because it's not a language that anyone ever thought they would need until they need it.
Thank you for that. That's a good point about, the partner and what the partner is going through, being, the partner and also the caregiver, possibly. So with that said, thinking about, someone has a question, thinking about body issues, right? So if someone asks, I'm having body image issues, is it normal to not want to engage with my partner sexually? And what suggestions do you have for that person?
So I'll tell you a little bit of story to answer that question, because I think it's highly, highly relevant. So I had, it's not an uncommon thing where I'll meet somebody who is having, an okay sex life. They're having intimate moments, they're having intercourse. She's fine with it. He is not fine with it, because there are rules in place And the rules might be never with the lights on, never without a camisole, not allowed to touch me here. And those rules didn't exist prior to cancer. Um, but it all goes to the idea and the importance of body image, because partners feel like they're not being heard when they tell someone with cancer, you're still beautiful to me. In fact, you're more beautiful now than we first met. But you're living without a breast, or your implant had to be removed, or you don't have hair. Honestly, the most critical voice any of us will ever hear, and it's amplified, I think, in metastatic disease, is the voice of the person who's staring back at you. And that is not anything to be trivialized, but it's something to be acknowledged that, you know what, if you look at yourself in the mirror and you're not seeing someone you're comfortable with, you can own that. You can own that, and it's yours. And no one should be able to tell you you're being foolish because you don't see what they see, because you're seeing what you see, and that's really important about that. It doesn't mean that things cannot get better. One of the studies that was done in people with body image after mastectomy or breast cancer surgery, and it was published actually in the Journal of Clinical Oncology, I believe, is that group therapy helps. Your community of people living with disease can help you recover a newer normal, where you may never get to the point where this is the body I love like I did before I had cancer, but this is the body you accept and embrace. And that can happen with the support of community and group treatment, group therapy. So there are ways to improve. And I think the one thing that I do help couples where body image is an issue try to go forward is to get to the point that the other person's perspective is not only acknowledged, but embraced as well. That it is not foolish. That's not that she isn't listening to you. And in fact, she appreciates everything you say to her. But this is where she is when she looks in a mirror. And then to create, a common plan. Maybe it's to do something called sensate focus exercises, where we're going to work on intimacy and get to the point where we enjoy intimacy, not because it leads to intercourse, but intimacy in its own right. And sometimes these shared homework towards a shared goal is the first step people can take to recovery.
All right, thank you for that. So you're saying, so you have homework for the couples when they come to see you?
Yes, sometimes I do. Yes. So, the first thing that I think is really important in the work I do is explain this model of female sexual health, which I think is just so important, but not just for her, for him, and for her and her partner. They both need to understand it, because I've learned even among lesbian couples, it is not obvious that women's sexual intimacy is not tied to intercourse, that desire can be interrupted by breast cancer, and that even if they do have one native breast, it doesn't mean or negate what they've lost with the breast that had cancer. Yeah.
Thank you for that. Okay, the next question. So if sexual health is part of managing quality of life, why do you think more doctors are not proactive about it? They don't discuss it.
I think it has to do with there's a concept in sexual health called the schema, sexual self schemas, and it's really influenced by the neighborhoods we grew up in, our role models when we were children, what we watched in our teenage years, our own sexuality, our past sexual experiences, our church and religion, and those we surround ourselves, what they did with their sexuality. And so it's almost the way I explain it to people is, say you are on TV and you're flipping the channels, and then all of a sudden you're seeing an X-rated movie with full-on penetrative intercourse. Some people will turn off the TV and walk away. when discussed. Others will linger and say, oh, that's interesting. Others will watch it and become aroused. And others will just not think anything of it. Just turn the channels as, yeah, whatever. That is essentially one schema. Okay, so your doctors have a schema as well. Okay, and they may or may not be inherently comfortable talking about intimacy and sexuality. And the last thing I think I want any clinician to do is to attempt to go into something they have no idea what they're doing and leave someone with a sense of shame or embarrassment that they even brought it up, because that's just not appropriate. I think what I'm hoping for is that centers have access to people who are interested in exploring and helping people discover this. You know, we started a clinic in the bone marrow transplant program at Mass General, and you know, when it was first started, nobody referred to this clinic, but within a year, clinicians were asking their patients about sexuality because they had the resource. So I think having the resource is part of the thing that's going to help people ask the question. But if there's no resource, then it's very difficult, because people are like, I don't know what to tell them. And I think, you know, that's the unfortunate state of affairs right now.
Thank
And
you.
has been for a decade.
Thank you for that clarification. I think we have time for 2 more questions. So then we have to leave. So we have a question from the audience. I understand that oils for lubrication should not be used in conjunction with condoms. Are there any limitations to the use of moisturizers when engaging in vaginal intercourse using condoms?
So that's an interesting question. And boy, I wish I could tell you that this has been an extensively studied in people with cancer, and it has not. Vaginal moisturizers can be used, but not they shouldn't be used immediately when you're about to have sex, about to have intercourse. Typically, again, like my recommendation is, you know, to use it as something you use daily. Moisturizer should be used every day, at least 5 times a week. And then as part of the preparations for intercourse, it can be used an hour before intercourse, but not as a lubricant itself. So in that way, it is safe to use because it's not meant to be used during in a penetrative intercourse.
Okay. Okay, thank you for that. And then we have a question from our Facebook Live. I was diagnosed with stage 3 breast cancer in 2020. Did treatment. Did a mastectomy on the left. I'm having sexual issues. I do have the urge at times, but when I try, it burns real bad. I'm sorry for what my husband is going through. Is there anything that could be used for this purpose? That's a great question that, you know, kind of overall.
Yeah. Yeah, you know, I think, you know, the symptoms of the genital or urinary symptoms of menopause tend to be worse in younger people, especially if we throw them into menopause. And it's not to say that those of us who are over 50 experience menopausal symptoms because they did that. My patients absolutely do. However, what I think is really important, people are complaining of the chafing or the burning. That could be even be wearing very tight jeans, for example, in everyday life. If you're having bleeding with intercourse, or you're gritting your teeth because of either pain or the burning, as was mentioned, you really need a pelvic examination. It all starts with the exam, because we need to know what's there. Things that I prescribe because of various things, sometimes if someone has evidence of inflammation of the vaginal vault, or if they have areas where the vaginal wall is torn, there are little tears, microperfs, those need to be treated differently. And I don't want people to say, oh, just use this lidocaine without ever having a pelvic exam, because there's many things that we need to see and diagnose. I've even seen scarring of the clitoris from an aromatase inhibitor. It's called clitoral phimosis, and that can really impact the experience of orgasm, for example. But it all starts with an exam. So my general advice, if you're having any symptoms of pelvic discomfort, with or without intercourse, mind you, You need a good pelvic examination.
Okay, thank you for that. So you're saying have a pelvic examination. That's very important for all of the issues that may be happening. And then further to that, also seek you out, or seek someone out to discuss these issues and to work
Right.
with.
Yeah, I mean, most gynecologists are able to discuss and manage atrophy or dryness or the chafing, because it's really the symptoms of menopause are universal. It's just that they tend to be more severe in people who experience cancer-related treatment menopause. But if I had several younger women do laser therapy because the symptoms were so terrible, and they did have a benefit to them immediately. Whether or not it persisted is a different story. But the treatment algorithm will depend so much on the pelvic exam.
Okay, thank you. So is there any final words that you have for everyone before I know you have to leave? But this was such
Well, I would just say that Nancy is an amazing colleague as well as a person. I'm glad she invited me to do this. And really, don't let anybody tell you that, don't let anybody tell you at least you're alive if you are having issues. You all deserve the sex life you want. That's the most important. The sex life you want, not the sex life I think you should have. The sex life you want. You deserve that. Don't forget it.
I agree 100%. Thank you for that. Advocate for yourself in that area. Yeah, for sure.
Exactly.
Thank you so much, Dr. Dizon. It was a wonderful hour with you. Minutes. We really appreciate having you. And so now, I believe that's the end of the questions. I think we'll pass it on to.
Right back to you. Thank you so much, Nancy. Phenomenal moderating, and Dr. Dizon, absolutely a pleasure to hear you speak. Your reputation preceded you, and so it was definitely a great discussion with a lot of really useful information, and I'm really grateful we're going to have this as a resource moving forward now for our MBC patients. So today's session was recorded. I know we had that question in the chat, so I'm just going to say it live as well. It was recorded and it's going to be posted to our landing page and our YouTube channel really soon. It'll also be emailed out to everyone that registered. You can also view previous sessions. Again, it's a new topic every month, so you don't have to sit through every single one if you don't want, but if there's something that's relevant to you, you're interested in, or could be helpful, it's all there. So please help us spread the word with your family, your friends, your healthcare professionals, anyone that you think might find value in this. We want to acknowledge our sponsors just one last time before we sign off, because again, their generous support is what allows us to have these topics and these speakers every single month. So thank you to AstraZeneca for being the technology sponsor. We also need to thank GE Healthcare, our premier sponsor, and last but not least, our signature sponsors, Walgreens and Daiichi Sankyo. So last ask, guys, I promise. Please help us by completing the survey. It's in the chat feature. I personally look at them, so it really does help us figure out what we're doing right, wrong, where we're missing, what topics need to be covered. So please be honest, and we'll do our best to incorporate your suggestions moving forward and always keep growing and doing better. So the next Impact Series event is actually next week. So it'll be September 11th. We'll hear from 2 lawyers who work in estate planning, and they'll be sharing some free and low cost resources to help navigate settling your affairs. I know this is a tough topic, and maybe no one's quite ready to hop on and talk about it with us, but we will be recording this because it was requested by MBC patients, and as difficult as it is, it's important that we provide these resources. So we look forward to having you if you're in the space and need the information. You could register now on our landing page. So thank you again for joining today, and a special thank you to everyone who made this possible, and stay safe and stay connected.